and welcome to another episode of Cutting Edge Health. Today, we're talking about what aren't they telling you about arthritis in the back and the number one recommended treatment. Sneak peek, today we're going to give you some insight about really radiofrequency ablation, which is that traditional treatment. And if I was recommending this to somebody I cared about, would I have it done? No. And we're going to explain to you why. If we haven't met, I'm Dr. Orlando Landrum, and we're going to talk about radiofrequency ablation, which is probably one of the most common treatments. But first, we're going to start with arthritis of the back. Where does the arthritis come from? If I was giving you a simple diagram, it would look a little something like this, which is all over the place. There's multiple different things that cause inflammation and damage to the tissue and cartilage. These things result in pain. Pain is typically worse when you go from a bending position to straight, when you bend, when you twist, when you arch your back, anything that is going to be something like golf, gardening, that requires you to have extension and pressure on the facet joints. But it doesn't always have to be that. Sometimes it can be cold weather. Sometimes it can be other changes in barometric pressure. The fact of the matter is arthritis is probably the most common presenting problem in the back. Greater than 50% of people under the age of 30 actually have arthritis that's present in the back, but they won't necessarily always feel the pain. And those individuals who are greater than 60, about 95% of them have arthritis in the back. So what's the traditional treatment? Well, one of those traditional treatments is an injection in the back, which no one really loves or likes, right? So is it worth it? And that's what we're going to talk about today. One of the main treatments for that is something called radiofrequency ablation. We're going to give you the background behind it so you can understand it, so you can know it, and so you can make an informed decision. So when you look at the spine, it looks like this, right? We can see this picture of the areas of the vertebral bodies and the nerve root that comes out. And traditionally, when we talk about being able to try to make arthritis better, many doctors, I would say wrongly, talk about cauterizing a nerve. And most people think about this big nerve that's present, but that's not the nerve that's actually treated. The nerve that's actually treated is the nerve that goes to the joint. You can see the small little branches that come here that go to the areas of the joint off of the big nerve. They are only sensory nerves, meaning they do not control the aspect of muscle traditionally, although you can see this little outset is one of the reasons why this may not be the best procedure, and as a fact, it really isn't, because it actually does help the muscles that form a brace to our back, specifically the multifidus, be robust. And when those nerves actually are impaired, which is the whole point of trying to make the pain not be present, it makes the muscles shrink. So your natural bracing is gone. But nonetheless, it doesn't impact your legs or make you weak or anything like that. When people think about back pain that's coming from arthritis, they think it's going to sit all in the one spot and they should be able to put their finger on it. But that's not the way really arthritis kind of works. When we look at that arthritis or facet arthropathy, to use the fancy terminology, can go all over from the front of the thighs to in the inguinal region to around your belt line to into your glutes, all the way down the posterior portion of your legs, and sometimes into the areas of the calves. So joints can be really diverse in terms of how they present in pain, and they can be confusing, and people will think that it's a disc. But it's traditionally not just a disc. It's arthritis is the primary reason, though you could have a mixture of different things. And when people hear joints, they think, oh, well, this is the same type of thing where you probably have the same joint throughout the spine as what you'd have with your left and right knee. They're both pretty similar, except reversed. Well, it's not. So when you take a look at the back, we can see this is a picture at a higher up level, L1, and it goes progressively inferior or downward to L5S1. And the joints are the areas that sit in this area, in this region that's kind of at the 5 and 7 o'clock positions, right? And those areas are different depending on the level that you're at, and how that is impacting because of bending and twisting can be certainly really key to what it is that you feel. One of the things that to be looked at is how does the physical examination go when you try to assess for the facets? And when you evaluate for the aspect of facet joint levels, we can see that there's different strains that cause different things to be worse, whether it's forward flexion or extension or right bending. So what most people do on exam is to do it all. They have the person bend and they have them lean back to see is that painful, and the same type of thing on the opposite position. And they'll press and push there to see is that the case. But one of the definitive ways is to be able to look at it under imaging. Historically, we've used MRIs to be able to do this, but CT also does probably even a better job. What we see is these joints. You can see them as kind of like ears or eyes in the top right-hand corner or top corner of each one of these pictures. The picture on the left top, bottom left, bottom right is from normal to degraded facet, and we can see this degree of closure and issue and challenge. So what most people used to do for this many years ago is to give steroid into the joint. And what they found is that steroid over time would break down the cartilage and cause other problems, and it maybe just what really wasn't worth it. So then there became this premise of treating the nerve to the joint, as I alluded to earlier. And there's a number of different ways to do that. But at the end of the day, what you want to do is to do these diagnostic blocks where you give local anesthetic into that site, and you try to see if you can be able to determine what's the pain relief that's present. And then after that, you consider, if those blocks show that there is relief, doing something that's called a radiofrequency ablation. So what is a radiofrequency ablation? Well, what it is you place a special type of needle tip that's present at that tissue, and you use this, as you can see in this picture, where there's a heated area that then targets the tissue, and it makes it insensate. It makes it not function, right? So what most people would say is, if that's the case, I will take that 9 times and twice on Sunday, all the way, love it, it's perfect, because I'm going to feel better. And you will, for a short period of time. And much like the Friday the 13th movies, it gets up and it comes right back. And that is one of the main reasons why I feel like, although RFA can be useful, is not the best treatment. So when you do this treatment, or your doctor has this treatment and does it for you, what you'll see is they try to place the needle specifically on a spot. It really has to be meticulous and localized to one region in particular. And that region varies from level to level, as we showed you before. If the doc is on top of it and they get everything right and they do the guidelines, which basically say you should use a temperature somewhere between 60 to 80, sometimes greater than that will last for 60 to 90 seconds and potentially 1 to 2 lesions, you'll get benefit. But then, as mentioned before, after 6 to 9 to sometimes 12 months, it comes right back, and then you have to do it again. So does that differ, and can you use it in other areas of the body? Sure, you can use it in other areas of the body. When we go down and we take a look in the regions around the SI joint, so lower in the glute, below the belt line, there's different ways where you can line them all up and do multiple different needles in the area. This is called a palisade type approach, or you can do it in regards to the foramen. So each one of these dots is where a needle would be placed to try to make that gluteal or SI joint region better, and it can be able to provide some relief. And sometimes that's better than considering doing a fusion. It also can be used in the periphery, where you can be able to treat things like knee pain, and you place the needle and you're able to target the nerves that go to the knee, or be able to target the hip. And there's different protocols for being able to use that, where it's the element of placing that electrode or that needle that's there, and it's typically a little bit longer length of time. Hotter temperatures, 70 degrees to 90 to 180 seconds. And the same thing in the occipital region up in the head. It can all be treated. So why is there something wrong with this approach? Well, the spine is not a separate thing. It's interconnected. So that makes for a much more interesting evaluation and treatment, and more complex. So one paper that references this is a paper put out by Dr. Hauser. And so one of the things that they talked about is how the spine and joints really work. So you can see, again, a picture from the side, but this time we don't just see the vertebral body, but we also see these ligaments that are present everywhere. So we have the ligaments in the front, the anterior longitudinal ligament. We have the ligaments that are present in the back, the posterior longitudinal ligament. We have the ligamentum flavum. We have the intertraverse ligament. We have the spinous process and interspinous ligaments. And so we have ligaments up the wazoo, if you would. And so what do these ligaments matter, if at all? Well, one, they provide stability. But two, if they're not functioning correctly, they can also cause pain. And so one of the things that we've seen is that this Hackett referral patterns is where ligaments can have issues and challenges, and by us trying to be able to treat them to make them stronger, we can be able to alleviate pain that's present in certain areas in the region. So when we look at this, why do we have pain to begin with? Well, one of the things may be just wear and tear, but one of the things may be there's an imbalance in a different area. And so this is the same picture from the side, and we take a look and we can see the disc is reduced in the bottom picture. And that reduction in the height of the disc ends up changing the ligament angle and how it's associated with the superior and inferior aspects that can result in arthritis, and a change in the load and changes in the ligament. So we have multiple different reasons for why we have pain, right? So there's thought processes about, can we target these ligaments specifically in order to be able to make stability better and make patients feel better? And yes, you can be able to target the ligaments in order to be able to provide support. The ligaments all throughout. There's multiple different places to be able to get after. But what I would say is, what do you use to target those ligaments? Some people will say prolotherapy, where you put kind of a mixture of glucose. I would say something different. So this paper actually looked at platelet-rich plasma and just tried to divine, is there treatment options that may be better than just steroid alone? And what they've been able to find is that PRP, platelet-rich plasma, coming from you, which is autologous, has been incredibly useful. And when you compare it to a steroid injection, one of the things that we see is that it's longer lasting, and on top of that, it's traditionally more effective. So when I would make a recommendation, if price was no object and people said, I want to be better, and hopefully better for a sustainable period of time, it would be PRP, because you can be able to treat the area, make it better, and not have this episode of it coming back and then you kind of winding up on the short end of the stick. We don't need that. What we would prefer is to be able to get you back into the driver's seat and leading the life that you deserve. Thank you so much for your time. Hopefully this video was helpful. If you found that is indeed the case, give us a like. If there are videos like this that you'd like to learn more about different topics and what is the real deal about mental health and physical health and how the two intertwine and what to be able to do about it, then subscribe to our channel. Thank you so much and have a great day.